Mr. Chepa. My task is very simple. First of all, to thank Mwenya and yourself for making sure that this happened. We can go over to the next slide. And of course, thank the rest of the network for joining us. Yes, so our schema, essentially, we are going to go through HIV surveillance as a whole and all the components that are happening in the country, at least the critical ones. Aside recency surveillance, case-based surveillance, mortality surveillance, and surveillance that happens in our priority and key population, the Ministry of Health also does HIV drug resistance surveillance. That includes primary HIV drug resistance surveillance, secondary surveillance or acquired surveillance, acquired infection, acquired resistance, which we do in patients that are already on ART. And also now we will be embarking on drug resistance among people that seroconvert while on PrEP. At this point, I'll let Mr. Chepa take us through the objectives. Just to mention, they are quite different from the ones that were shared because we realize that it may be overwhelming for our network and we plan to break it down over a number of sessions. So we can go to the objectives, Mr. Chepa.
Thank you so much. By the end of this discussion today, we'll be able to discuss what HIV surveillance is, and then also outline some different HIV surveillance that are existing in Zambia currently. We'll also illustrate the role of HIV surveillance and how it plays in the response to the HIV epidemic. Just to start, we are in the drive to end the HIV epidemic. And in response to the 95, as shown on the screen, in the Zamfir 2020-2021, we realized that we attained 89, 97, and 96 respectively, meaning that as a country we are doing quite well to meet the targets that have been set for 2030. But you will note that despite meeting the targets as we have, we still have gaps that still exist in our surveillance system or in our implementation of the HIV program. For example, reaching the pediatrics, reaching the adolescent girls and young women, reaching just the men themselves. So we do have those challenges that are there. And then there's also undiagnosed people living with HIV and those who still have detectable viral load as a source of infection of HIV. So because of these issues that are still existing in the HIV implementation, there's need now to do an HIV surveillance so that we can begin to close the gap that is existing. So in closing the gap, this is what we are doing as a surveillance team. The first is to have an MOH-led data equity hub where the data is going to be reviewed even further, where deep dives into the data is going to be done. And then we'll also track the progress towards our 95, 95, 95, and the high coverage of HIV services for underserved populations, as it were. Then we proceed now to look at specific interventions that we need to focus on. For example, the children under 15 years, the adolescents and young people, the key population in underserved geographies, as it were, among other populations that we need to look out for, some of which I'm sure Dr. Sombo just mentioned a bit earlier. So where are we? So how HIV was discovered, it was through a robust surveillance system somewhere in the USA, in Los Angeles. So we hear that they noticed a strange pneumonia that would happen in gay men. And because of this, it trigger them to investigate. And that is how, as early as 1981, HIV/AIDS was discovered through the surveillance system that would go there. However, here in Zambia, we noticed that our first case of AIDS were reported in 1985. And by 1986, April, the disease had been included among the notifiable diseases in our surveillance systems. And by 1987, the government had already implemented a large coordinated program to combat HIV and AIDS. So today we are going to focus on what HIV surveillance basically is. HIV surveillance, as per definition, is an ongoing systematic collection, analysis, interpretation, and dissemination of data regarding a health-related event. So what that sentence means essentially is that you collect data, you look at it so that you can have an action. So in short, to define surveillance, we say data for action. We collect data so that we can respond to whatever we are seeing in the data. Now, bring it down to HIV surveillance. This is going to do the same way that we have said, but it's going to focus mainly on HIV infection and AIDS. So it's going to look at all the processes, regardless of the stage, regardless of where we are, or where the patient is in the disease process. So it begins from the preventive issues to the actual disease itself and everything else in between. So ultimately, the goal of HIV surveillance is to provide the comprehensive picture of how the HIV is evolving so that we can support prevention and the health activities that are going on in the program. So as we proceed, we'll just share the poll question here, which is talking about surveillance. We'll allow for a minute so that we can take that question. Okay. So I'll read the poll question aloud. Passive surveillance is when a clinician notices an increase in the number of patients from the same residential area presenting with advanced HIV disease in the same week and organizes a response to assess what could have led to the noticed increase. So if you think that is passive surveillance, then we can say true. And if we think it's not passive surveillance, we can respond with false.
Okay,
you can see some answers are coming in.
Yeah, so we have, so passive surveillance is when a clinician notices an increased number of patients from the same residential area presenting with advanced HIV disease in the same week and organizes a response to assess what could have led to the noticed increase. Option A, true, and option B, false. So we have just slightly under 50% that have attempted the question. I'll give it a few more seconds. Okay, so I'm going to end the poll over here. So we have 71% that have opted for option A being true, and 29% that have opted for option B, false. Over to you.
All right, so we progress, Doc?
Yes.
All right, thank you. Okay, so we'll try and dive and look at the differences, the different surveillance systems that we have. Although we'll just limit our discussion to those two, the active surveillance and the passive surveillance. Of course, we have other forms of surveillance like integrated surveillance, we have event-based surveillance, we have indicator-based surveillance, and so on and so forth, the sentinel surveillance, and so on and so forth. But for this discussion, we will limit ourselves to passive and active, because these are the two by which all other surveillances are based on. So the passive surveillance, this is where a health institution receives routine reports submitted from health facilities. All right, this includes the hospital, clinics, public healthcare unit, communities, or other sources. So in this system, an institution, it could be at the hospital, it could be at DHO, it could be at province, it could be at national level, or any other unit that is looking at the data. So you receive reports as they are coming in, and then you analyze the reports and you look at the reports as they are, so that you can pick a picture. So basically, passive is where you are at an institution and you are receiving reports and you are receiving data as it is coming. Then in passive, there is no active search for cases. So you are basically where you are, and the cases or the reports are coming in, and then you begin to go through. And this is the most common form of surveillance that occurs. The way that we do submit our TDBs, the way we submit our HI1 and HI2 and other reports. So as those reports are being received at a place where they are being aggregated, that is a form of passive surveillance. So they use routine reports and routine health management systems, information systems, and other public health information systems to gather data and interpret and look at the patterns, and then see if a response is required, or if policy needs to be informed to respond to a certain observation. Whereas on the other hand, we have active surveillance. Active surveillance is the ongoing search for cases in the community or at the health facilities. So in this form of surveillance, you know exactly what you are looking for, and you go out there to find that which you've already defined and what you want to get out. So it involves regular contacts with key reporting sources. So you need to discuss with the frontline health workers, which includes the clinicians, which includes the lab people, which includes the nurses, and everybody else that is involved in this data collection. And key in active surveillance is physically moving to the source and carrying out record review of data. This also involves where you may want to actually go in the community and look for something that is unique or peculiar that is going on that you want to respond to. An example that we wanted to share for this discussion is in Recency HIV Surveillance, where when you've done your Recency tests, you look at the hotspots, and those hotspots are going to inform you. So those reports are going to inform you what is going on in the hotspots. And then a team from either the district, the province, or national level, or a combination of all that team is going to respond direct in that area where the hotspot has been identified as a form of response. So to summarize, this form of surveillance, as per se, is in active surveillance, you already have an idea of what you want to see. All right, and then you go out there to actually look for a specific disease or a specific definition that you already have. Whereas for passive surveillance, you are at the health center, you are at DHO, you are at the province, and you are looking through the reports to get the information, as it were. Having said that, we'll go back to our poll question that we noticed there. I noticed we had more responses for true, but our answer in this case, because we have that line there, which is bolded, which says organizes a response. So once that is done, this now becomes active surveillance and not passive surveillance. So the correct answer for this poll question would be false. Thank you so much for having taken part in that one. So I'll go to another form of surveillance that we are doing in Zambia. This is our first surveillance that we are going to discuss. Sorry, these are the systems that we have in Zambia. So we have Recency that was begun around 2020 and is still going on now. And then you also have HIV mortality surveillance that began around 2018. And then we also have case-based surveillance that began, should be much earlier than mortality, but around 2017, 2018. And then we also have other forms of surveillance that began as early as the program was rolled out to the entire country around 2007 and 2007 for priority, for populations, and other surveillance systems that we have. So our role as the surveillance team is to bring together all these different surveillance systems, integrate them into one, and have what is known as the HIV surveillance, where we bring all the surveillance systems that are existing in silos or that are specifically looking for a specific thing, bring them together for deeper dives and triangulations.
This brings us
I don't know if I can.
Sorry.
Yes. I don't know if I can take questions.
So we'll
Okay.
take the questions towards the end of the presentation.
Okay.
So we'll move on
All right, thanks.
to our next slide, which is
Okay.
another poll question. So this brings us to our second poll question. Let me just launch it. Okay, so our second poll question is: a weaker anti-HIV antibody binding strength, which is avidity, is classified as recent, meaning the individual is likely to have been infected within the last 12 months. Option A, true, and option B, false. So a weaker anti-HIV antibody binding strength, which is avidity, is classified as recent, meaning the individual is likely to have been infected within the last 12 months. So let's all ensure we participate in the poll questions. Your answers remain anonymous. The weaker anti-HIV antibody binding strength, avidity, is classified as recent, meaning the individual is likely to have been infected within the last 12 months. Option A, true, and option B, false. Okay, so I'm going to end the poll question now. Okay, so we have 73% of the network that have opted for option A, which is true, and 27% that have opted for option B, false. And I'm sure we'll discuss this along the way. Over to you.
All right, thank you, Doc. So before I give out the answer, I'll go to the next slide and then just try and understand what recency is. Recency is a test for recent HIV infection. And this test called the test for recent infection, TRI, it measures the antibody binding strength, or what is known as the avidity. Okay, so the antibody the antibodies that look for the surface antigens. All right, so the antibodies, the way they work is that they bind to the HIV surface there. So as the HIV infection progresses, you find that even the way they bind, it becomes much stronger to the virus as it binds to the virus. Whereas if it's weak in binding, this is known as a recent infection and is most likely to have occurred in the last 12 months. So a stronger binding strength is classified as long-term, while a weaker binding strength is classified as recent. So the long-term one, the infection would have occurred over a year ago, whereas the recent test would have occurred at least within 12 months. So this information is valuable as we are describing the evolution of HIV epidemic. It's actually able to tell us where the new infections are so that a response can actually be initiated. It also informs us as well to say, are these new tests that we are having a real increase, or people are retesting for whatever reason or the other? Because you may want to base your incidence on the recent infection as opposed to basing it on the new HIV infection from the HTC registers. So in fact, in the HTC, there are those who may not have disclosed to us that they are already positive, but due to one reason or the other, they want to retest, and then they will still not be disclosed. But when you do a recency test, you're able to tell which one is a true recent infection or a true new infection, as it gives us the option to say this one was an infection within the last 12 months or so. Just a moment. Sorry. Yeah. Sorry, my screen is freezing. Yeah, so when we go back to the poll question, the answer to the poll question will be true. As we saw to say, if the binding strength is weak, then this means that it's a recent infection that occurred in the last 12 months.
Mr. Evans, we'll be discussing the answers from the poll question towards the end when we re-poll, so we can move on with the presentation then.
Thank you, Doc, for the guidance. Recent infection surveillance systems in Zambia were established around the year 2020. And these are protocol-driven activities. And then we use the recent test for recent infections which has not yet achieved the WHO pre-qualifications. And there's also a waiver for consent. Results are not returned to patients or are not returned to sites, as it is still a program and has not yet been pre-qualified by WHO. And currently, as we are speaking, it is active in 27 districts across the country, as shown there. Then the challenges that are there is that because of the way the test is designed, it is possible to have false recents. Okay, so this is a big possibility. And why it's a possibility is that the avidity begins to decline as when HIV is suppressed for a long period. So for people who've been on ARVs for a while, they may have a weak avidity as well, which may lead to false recent. And then you also have elite controllers. You also have specific subtypes. The TRI is specific to HIV-1 and does not respond to HIV-2, and this might create a false results. So incorporating the marker of chronic HIV to reclassify from recent to long-term. So to address that challenge, what you want to do is you also look at other markers that would explain a recent infection. So if the RITA is positive, you also look at a viral load. If it is unsuppressed, then it's most likely it's a new infection. But if the viral load is suppressed, then this one will be reclassified as long-term. Then we also know that the viral load declines rapidly over days to weeks after someone has been put on ART, and is undetectable in most persons within at least 3 months of being on treatment. So in the treat or error, the assumption is that someone who reports being on ART or has a viral load suppressed is not a recent infection may no longer hold. This remains an era that requires further investigations as experience is being gained with recent testing in the test or era that we are in. So basically, this is a treating the testing algorithm in Zambia, where everyone who is HIV positive, a newly diagnosed HIV patient is going to be tested for full blood count, chemistry, viral load at diagnosis. And then they will have to opt out in the recent test, in fact, in the recency test. So they'll be given an option whether to be tested or not, and then they opt out or they agree to actually be tested. So newly diagnosed HIV patients with unsuppressed viral load will be classified as recent or long, according to the RITA. This assumes that HIV elite controllers compose of a very small proportion among people who are living with HIV in Zambia. In summary, recency is a new tool to monitor the progression or the evolution of the epidemic as it is occurring in Zambia. And then recent surveillance can be used to identify suspected hotspots that serve as a signal for ongoing HIV transmission. Recency hotspot investigation involves the following steps. First of all, you need to identify, then you confirm, you prepare to go in the field, then you actually investigate and see what is going on. After the investigations are done, you put in recommendations to try and address the issues that you're able to find. And then after some time, you want to go back and for follow-up, you see how the recommendations are being implemented. Recent infection signals can identify gaps in the HIV program and is a tool to potentially interrupt HIV transmission and improve the HIV response in Zambia. So we go to the poll number 3.
Okay, so this brings us to our third poll question. Let me just launch it. So our third poll question reads, HIV case-based surveillance is a routine gathering and following up of all patient-level information from the time an individual is identified as newly diagnosed, initiated on treatment, viral load monitoring, adherence, until the point of separation, either through death, loss to follow-up, or other reasons for leaving the program in Zambia. Option A, true, and option B, false. So HIV case-based surveillance is a routine gathering and following up of all patient-level information from the time an individual is identified as newly diagnosed, initiation on treatment, viral load monitoring, adherence until the point of separation, either through death, loss to follow-up, or other reasons for leaving the program in Zambia. Option A, true, and option B, false. Okay, so I'm going to end the poll over here. So we have 91% of the network that have opted for option A true and 9% that have opted for option B false. And I'm sure we'll see it as we go along. So over to you again, Mr. Avenzo.
Thank you. So we'll try and look at what case-based surveillance is in the detail. So HIV case-based surveillance is a recommended component of HIV surveillance. The scale-up of HIV care and treatment services must be accompanied by an effective system of recording and reporting of newly diagnosed people living with HIV, newly initiated in care, and may already have been on treatment, those who are very suppressed, treatment failure, and those who die from HIV-related causes. So it involves a whole cascade from the time someone is identified as having HIV all the way to the point of separation for one reason or another. The HIV case-based surveillance utilizes routinely generated individual-level information on people living with HIV. Each person living with HIV, it has a unique identifier which will make it easy for this individual to be followed over time as they continue accessing the care. And then monitors entire spectrum of the disease, from the initial HIV diagnosis to advanced and severe HIV infection, opportunistic illnesses, and including death itself if in an unfortunate event it occurs. So this is how the HIV cascade, the CBS cascade would look like. So events are collected at different points. From the time a person is identified as HIV, and then they enter into care, they are put on treatment, and we check their initial CD4, the follow-up CD4s at all those intervals that are existing. And then we also look at the vital load results and the follow-up vital loads as they occur. Then it also involves the actual HIV disease itself, including death if in an unfortunate event death occurs. So this involves a whole cascade, and it looks at information at the patient level as opposed to looking at information at an aggregate level. So what CBS is about implementation of the HIV CBS will allow the country to effectively monitor the trends in prevalence of HIV infection. It will characterize the affected population, and it makes it easy to put in intervention for these populations once they are identified. To identify the number of persons in need of care and treatment, to allocate care, treatment, and prevention resources, to target and evaluate interventions and prevention programs, to accurately profile the HIV pandemic, the HIV epidemic over time, and to provide a context for monitoring and evaluation data. Go to poll number 4.
This brings us to poll question number 4. And poll question number 4 reads, HIV-related mortality surveillance focuses only on death associated with HIV and not any other causes of death, as this informs a program on the burden of the disease. HIV-related mortality surveillance focuses only on death associated with HIV and not any other causes of death, as this informs a program on the burden of the disease. Option A, true, and option B, false. So HIV-related mortality surveillance focuses only on death associated with HIV and not any other causes of death, as this informs a program on the burden of the disease. Option A, true. Option B, false. Okay, I'm going to end the poll question over here. So we have 55% of the network that have opted for option A, true, and 45 that have opted for option B, false. Mr. Evans, so back to you.
Thank you so much. So we dive a bit deeper into what HIV-related mortality surveillance is. So this gathers information on HIV-related mortalities mainly, and it helps us to understand the burden of the HIV disease itself. Over time, these data improve ascertainment of individual level outcomes. This can be used to measure treatment outcomes as part of routine patient monitoring and HIV care surveillance. Then tracking population level mortality trends of HIV. This can be used to measure program effectiveness, and when linked with expenditure data, inform cost effectiveness of the HIV program and the interventions that are being put in place. Suffice to mention that when we do HIV mortality, we know also that people who are living with HIV can die from other causes other than HIV. And as such, you want to look at all mortalities that are going on as you are doing the HIV surveillance, the HIV mortality surveillance. Then why are we doing the mortality surveillance? Is to provide an accurate estimate of HIV-related mortalities in the country and provide a baseline from which to measure the success or failure of current and future interventions designed to curb mortalities associated with HIV. And lastly, to provide policymakers and other stakeholders with relevant information for decision-making purposes. We move to poll number 5.
Okay, so that brings us to poll number 5. So poll number 5 reads, priority populations and key populations are one and the same. Option A, true. Option B, false. So the statement priority populations and key populations are one and the same. Option A being true and option B being false. The statement priority populations and key populations are one and the same. Option A, true. Option B, false. Okay, I'm going to end the poll over here now. So, Mr. Evans, we have 74 that have opted for option B, false, and 26% that have opted for option A being true. They are the same. Okay, so back to you.
Thank you so much, Chair. So we dive a bit deeper into what priority and key population are. So key population are defined as such. These are groups who, due to specific higher risk behaviors, are at increased risk of HIV. They often have legal and social issues related to their behavior that increases their vulnerability to HIV and STIs. So key population will include female sex workers, men who have sex with men, persons who inject drugs, and the transgender and the transgenders. The National AIDS Council, this is in Zambia, has been leading the coordination of the HIV response in key population. Then there's a database called NACMIS, which is being hosted by Naik and on behalf of MOH, and it conducts periodic surveys in these populations, the key population. On the other hand, priority population are varied and country and region specific, whereas key population are disproportionately affected by HIV in all epidemic settings. So priority population will include the youths, adolescent girls and young women aged between 15 to 24, the children and men who actually had to reach. All right, so we progress as to why do we need to have an HIV surveillance system in Zambia. So basically is to have a country-owned program that brings together all stakeholders, all the leads that have an interest in HIV, and they will discuss the challenges and opportunities that exist as they look at data. It also gives a deeper understanding, a wider view as you triangulate between different surveillance systems to pick the same information. Now, because of this, it is going to enhance the progress that Zambia is already making towards ending HIV/AIDS as a public health threat by 2030. And how and why we are integrating is to have a comprehensive data collection that is more holistic in nature as we are understanding how HIV epidemic is evolving in Zambia. It also provides a timely detection of trends of the disease. It improves the data quality and its accuracy. It enhances M&E, and then it optimizes resources which are available, especially when we live in a resource-limited country. And then it provides for cross-sector collaboration between government, for example, and the partners that work with government. In summary, HIV surveillance collects, analyzes, disseminates information about new and existing cases of HIV infection, regardless of the stage for which HIV, regardless of the stage, and it includes AIDS itself. Recency is a useful estimator for the incidence of HIV in Zambia. Case-based surveillance collects information about each case and the individual level, from HIV diagnosis up to the point of separation. Mortality surveillance is useful for estimating the burden of the disease and ascertain patient level outcomes and track population level outcomes of HIV. Priority population equity ensures success of epidemic control in all. Other surveillance by the HIV program include, but not limited to, drug resistance, ADH, among other surveillance systems that we have, even PMTCT, among others that we have. And those are some of the reference materials that we used for this presentation. Chair, I hand over to you. I'm not sure if it's Dr. Mwenya who will come. You guide, Chair.
All right, thank you. Thank you so much, Mr. Benz, for that lovely presentation. Quite insightful. Before we jump into the Q&A for this presentation, I just want to rerun the polls so that we can just see how much we've learned so far. Okay, so for question 1, passive surveillance is when a clinician notices an increased number of patients from the same residential area presenting with advanced HIV disease in the same week and organizes a response to assess what could have led to the noticed increase. So what could have led to the noticed increase? So passive surveillance is when a clinician notices an increased number of patients from the same residential area presenting with advanced HIV disease in the same week and organizes a response to assess what could have led to the noticed increase. Okay, so I'm going to Okay, I'm going to end the poll question here. So, Mr. Renzo, we have, again, 58% of the network that have opted for option A true and 42% that have opted for option B false. Your comments?
Chair, sorry for the misleading there. I think we've highlighted true. The answer is indeed false.
False, yes.
I think that was an error as well preparing the slide. So the correct answer is false.
Okay.
Why it's false is because of that insertion of organizing a response. Because when you organize a response at that level now, you are doing active follow-up and investigating the case. So it's now active because of that last inclusion there.
All right, great. Thank you so much for that. I'm going to launch question number 2. And poll question 2 reads, a weaker anti-HIV antibody binding strength, which is avidity, is classified as recent, meaning the individual is likely to have been infected within the last 12 months. Option A, true. Option B, false. A weaker anti-HIV antibody binding strength, which is avidity, is classified as recent, meaning the individual is likely to have been infected within the last 12 months. Option A being true, and option B being false. Dear network, let's all ensure we participate in the poll questions. Your answers remain anonymous and helps us understand whether we've learned something from the session. So please do participate in the polls. Okay, so I'm going to end the poll over here. So we have 92% that have opted for true and 8% that have opted for false. Mr. Havenzu.
So our answer is true. I think when you look into our guidelines, that's how the statement is. So as someone has just acquired the HIV, the avidity is much weaker, but as the infection progresses, it becomes much stronger. So those with a stronger avidity are long-term, and those with a weaker avidity are classified as recent infections.
Great, thank you so much for that. Question 3 reads, HIV case-based surveillance is the routine gathering and following up of all patient-level information from the time an individual is identified as newly diagnosed, initiation on treatment, viral load monitoring, adherence until the point of separation, either through death, loss to follow-up, or other reasons for leaving the program in Zambia. Option A, true. Option B, false. So HIV case-based surveillance is the routine gathering and following up of all patient-level information from the time an individual is identified as newly diagnosed, initiated on treatment, viral load is monitored, adherence until the point of separation, either through death, loss to follow up, or other reasons for leaving the program in Zambia. Option A, true, and option B being false. Okay, so I'm going to end the poll there. So we have 98% of the network that have opted for option A being true and 2% that have opted for B being false. Your comments?
Okay, so that statement is true because for case-based surveillance, as in the um, in the wedding itself, you are looking at a case and you want to follow them through and then see whatever is going on at each and every stage, from the time they enter the program to the time that they leave the program. You want to follow them through the whole process and at every point. And that is why it is called case-based surveillance.
Okay, thank you for that. Oh no, poll for, I don't have the question over here.
Okay. Let me share the question.
Slide.
Okay.
Okay, so HIV-related mortality surveillance focuses only on death associated with HIV and not any other causes of death, as this informs the program on the burden of the disease. So HIV-related mortality surveillance focuses only on death associated with HIV and not any other causes of death, as this informs the program on the burden of the disease. Okay, so I am going to end the poll question over here. So we have 55% that have opted for option A true and 45% that have opted for option B false. Still some confusion around this question, around this area, Mr.
Yeah. Yeah, I've noticed. In as much as the wedding is HIV-related mortality surveillance, you also want to follow up the HIV patients. What else are they dying from apart from the HIV? So you are not going to focus on deaths which are HIV-related in nature, but you want to look at all deaths that are going on and then see if we have HIV patients who are also dying from those other causes. Like, for example, it could be pneumonia, malaria. Even persons with HIV can still die from other causes apart from HIV-related causes. So when you are doing the mortality surveillance on this one, you are going to look at all mortalities that are going on, and then you track, did they also have HIV and what is killing them apart from the HIV itself. And then it also helps if most of your patients are dying from other causes and not HIV-related causes, then it means that your program is well working. We are not having people dying from AIDS, as it were, but they are dying from other causes. So as you measure how the program is well working, you will not only focus on the death caused by HIV, but you look at all death in general and then see how many people who died had HIV as well, even if the cause of death was not HIV, was not an HIV-related mortality. I hope I've clarified on that one.
Thank you so much. I think that was quite clear. Jump to our last poll question, which is priority population and key populations are one and the same. Option A being true, option B being false. Priority populations and key populations are one and the same. Option A being true and option B being false. So the statement, priority population and key populations are one and the same. Option A true, option B false. Yes, I'm going to end the poll question over here. So we have 95% of the network that have opted for option B false. Mr. Benzi, your comments on that?
All right, so the answer is false. These are not the same populations as it were. So the priority population are mainly vulnerable and are exposed to and are easily exposed to HIV. Whereas key population, these are mostly hard to reach. These are mostly the hard to reach, and that is where the difference between the two is. The priority, because of probably a lifestyle that they have, they are exposed to HIV. In this case, MSNs, female sex workers, and so on. Because of their lifestyle, they are exposed to HIV. Whereas the key population, sorry, I've mixed them. The priority are hard to reach, and the key population are at risk because of their lifestyle, as it were. So the priority will include just men in nature, because men are hard to reach with HIV services. The adolescents are also hard to reach. The young girls, the adolescent girls and young women, they are also a hard to reach population. So that is what is going to help us to differentiate between what priority population is and what key population is.
All right, thank you so much for that. That brings us to the end of our re-polls. And I think in view of time, we'll go and jump into a quick Q&A session. Before we jump, we've got a case-based discussion after this. So give 5 minutes to answering questions. So at this point of time, I'd like to invite our panel of experts to help with answering these questions that have been raised. So I'll start with the first question. We have, this is from Dr. Chanda. It says, thank you for your question. Kindly elaborate the limitations to use of spatial epidemiology as relates to HIV recency testing, where the interpretation that the test result positive around a test hotspot for recency implies increased transmission at the facility rather than the community, where the people being tested for HIV are coming from a faraway town.
Thank you so much for this question. I will take it. So I think I agree with you when you say that the results show more of what's happening at facility level as opposed to the community. But recency is not just used for facility-based responses. So when we find that a facility is reporting a higher than expected number of cases, we go in with a targeted public health response. And part of this then requires that we break down looking at what areas and what communities are serviced by this facility, where are the people coming from, which particular modality of entry has been affected the most. And then we break it down also by other demographic factors like the age of the people who were observed to have had recent infections. And then we mount a response that will be appropriate to this. So your question directly ties into the case study that we will be looking at. And so if I haven't answered your question right now, hopefully I'll answer it with the presentation that we're about to have. Thank you.
Great, thank you so much for that, Doc. And so our next question is, what are elite controllers? So I think elite controller has been there in the chat box. Somebody's replied. Elite controllers are HIV-1 positive individuals who spontaneously suppress viremia to undetectable viral loads, less than 50 copies, while maintaining an elevated CD4 count without the use of antiretroviral therapy. And then the other question was, do we do recency testing in both types of HIV-1 and 2? And got a reply saying that the only viral load we do is HIV-1, therefore we do not have recency tests for HIV-2 data. And then we have a question from Dr. Onoya, who's asking, is the recency testing a validated test, or is it still under study? And does the sensitivity and specificity of recency testing is it still questionable or below the standard?
Okay, thank you so much for these questions. So, in terms of, is it validated? Not yet validated by the World Health Organization. And so, unfortunately, that's why it's not included as part of, we can't say that it's a confirmed test. It's not yet validated by the World Health Organization. Why is the result not going back to facilities? So I think recency speaks more to a national program than it speaks to a facility level program. The national consensus is that we must test and treat. So even if I find we have 10 people at a given facility who have tested positive for recency, it's not going to change how the patients themselves are managed. We're looking at the national level in which we determine whether or not resources should be focused in a given area because that area has more infections than other areas in the country. So it really helps us to prioritize our response as opposed to actual activity at a given facility. And then the next question, I think, was, is the sensitivity and specificity still questionable or below the standard? So I think in comparison to other lag avidity assays, the sensitivity and specificity are still quite good, but that's for HIV-1, not HIV-2. And that's why our focus has been in HIV-1. Thank you.
Thank you so much for that, Doc. And then, so we have one comment from Eric. How can one access these very important presentations, please? I need access. So all these presentations are uploaded onto the IACO platform. So kindly make sure you register and you should be able to access all these presentations. I think in the chat box, those are our questions. If anybody has a question, to raise their hand, you may unmute and ask. Okay. Seems like there's no burning questions at this point of time.
There's a question that's just come up. Maybe the person can unmute.
So, question from Richard Watala, which says, I may have missed it. Is there recency testing in all the provinces of Zambia?
Thank you for this question. So at present, recency testing is only in 6 provinces. Thank you.
Yeah. Thank you. Richard, you may go ahead. See your hand raised. Richard Watala, you may unmute. And do you have any other queries? No? Okay. Okay. So unfortunately, is unable to unmute. So in view of time, I probably get back to your question. You can post it in the chat box, and then we can answer you in the chat box. In view of time, we'll move on to the next presentation. So for the next presentation, there's Dr. Mwenya. You're very welcome to today's ECHO, and we're looking forward to listening to your presentation, your case presentation. So. Okay. So,
Thank you. So good afternoon, everyone, and thank you so much for your engagement. And so we're just going to proceed with looking at a case study in recency. As you will appreciate, it's not an individual case, it's more on a response in, it's more of a regional case study than the usual individual case. So yes. We'll proceed with the poll. Thank you.
so our poll question 1 reads, according to the recency testing guidelines, should results from the recency testing be returned to the patient? And then the second one is, so that has 3 options. Option A is yes, option B, no, and option C, maybe. And then our second question reads, what is the lower age limit for recency testing in Zambia? Option A being 5 years, option B being 15 years, option C being 21 years, and option D being 25 years. So 2 questions. The one is, according to the recency testing guidelines, should results from recency testing be returned to the patient? Option A, yes. Option B, no. Option C, maybe. And then question 2, what is the lower age limit for recency testing in Zambia? Option A, 5 years, option B, 15 years, option C, 21 years, and option D, 25 years. Okay, so I'm going to end the poll question over here. So we have for question 1, which was according to recency testing guidelines, should the results from recency testing be returned to the patient? We have majority 72% that have opted for option B, being no, you should not. 26 are saying yes, it should be returned to the patient, and 2% are unsure, with the option being maybe. And then the second question, what is the lower age limit for recency testing in Zambia? 70% of the network has said 15 years of age. 26% have opted for 5 years of age, 3% for 21 years, and 1% for 25 years. Over to you.
Thank you very much. So okay, so as we proceed with the presentation. And so what we are going to look at is just what do we do with the recency information. And so when this information is collected by the different facilities and it's sent back, the information is then used to look at which areas of the country, or at least of the regions that are offering recency, have a higher than expected number of cases. And so the ones that come out as the highest are then considered as hotspots. So in the last, as also that had been said during the question and answer session, only 6 regions in the country are offering recency, as can be seen in the map on the right. And of these cases, in the last hotspot analysis that had been done, or at least in a previous hotspot analysis that had been done, the Copperbelt, Lusaka province, and Southern province had been found to have areas where there were hotspots. And so what we do with these results is we mount a public health response, and the focus then is to go in. So you select from these same areas, you go in and you look at the different facilities. So a specific response that was conducted, a bit of as a proof of concept in 2022, an area in Lusaka had been noticed to have had a higher than expected number of people with recent infections. And so when these facilities were checked, it was found that there were not enough staff in the HIV clinics. So these are the gaps that were identified if you look at the left side of the screen. And then there were not enough staff for management of at-risk adolescents and youth. There was insufficient information for those in need of key prevention services. And then there were inadequate services for both the youth and priority populations at community and facility levels. So when budgets were redone, when action points. So what happens when you have a public health response is that the Ministry of Health comes together with the PHOs, the DHOs, facility staff, community staff, and the different implementing partners. And then we come together and we mount a public health response. We look at what are the different gaps in the areas that have been found to have these hotspot analyses. Is the hotspot analysis correct? And so to check if it's correct, we triangulate the information with other MER indicator data. So we'll look at, is there adequate condom use in the area, distribution? Is there PrEP being distributed in the area? How much? Where are the adolescents accessing services? What is the staff in the facilities like? What's happening in the communities? Is there something that needs intervention? And so for the sites that were identified at the time for this proof of concept period, it was noticed that staff, with the reallocation of staff to strategic areas, so as opposed to having all of the staff in the ART clinics, you had some staff reallocated to other modalities of entry, where we identified and appointed adolescent counselors. And this was after it was noticed that most of the infection was being driven by the adolescents and young women. And then also developing just key appropriate messaging and sensitization on disclosure, because this was found to be missing in the given areas. And then the last point was also opening of DREAMS facilities, and these were to empower mostly the youth with knowledge on HIV prevention and treatment options. And so when this was done, some findings that we had, so the intervention, so what was noticed, so if you look at like, if we use index testing as one of the indicators, if you look at the index testing, and we can take the female index testing. So if you look at it in Q3 and Q4 up to Q1 of financial year 2023, we find like there were fairly low numbers of index testing. But after the intervention that was mounted towards the end of Q1, we find that there are more women being tested for, there's more index testing happening in the area. And then if we proceed and we look at PrEP, PrEP distribution in facilities, we find that, we find that before the intervention happened around July 2022, and then we find that as you proceed, you have more people accessing PrEP services. So this is PrEP new and not continued. And so we find that there are more people coming in to access prevention services, which is seen as a benefit of having this targeted response. In the interest of time, we had only put a few different interventions that had been done, but as mentioned, we had also spoken about dream centers, and had also, so these are targeted at the young women, and had this intervention was also done in the area. And so more women were able, young women were able to get access to services in a safe space with dedicated staff who had key messaging. And so this was just a short case study on recency, and we will get back to look at the poll questions. I think we had answered these already before. When we, so the first thing, I think the first question that was there, according to the recency testing guidelines, should results be returned to the patient? According to our guidelines, the answer is no. And the reason for that has been explained. This is being done as a national program and is used more to inform programmatic services than actual patient treatment. The patient will receive treatment regardless of whether or not they receive the results. And then what is the lower age limit for recency testing in Zambia? And although in other countries in the region, the lower age limit is different, for Zambia, we have accepted age 15 and above, because at this point, we believe that consent can be provided. I saw a question in the chat about recency being used for victims of sexual abuse, and it can be used for that. I think according to guidelines, I can be corrected by other members of the panel if this isn't the case, but it can be used for that. It's just that when we talk about it being an opt-out, usually it's offered at the same time as the baseline viral load. And so in most cases, the patients do not refuse to provide consent for this as the blood is taken at the same time. So thank you very much. I don't know if there are any other questions. Thank you. Back to you, Mr. Moderator.
Thank you so much for that presentation. Okay, so we will go into our Q&A session now. So if you have any questions, kindly raise your hands, unmute yourselves. You can post in the chat box. So there's a question from Mary. What's the threshold in terms of increase that's considered significant to trigger a public health response? And then we have something from Rokaya. Rokaya Jinwala, are you able to unmute and ask your questions?
Yes, yeah, my question was regarding recency testing with the sexual abuse victims. Sometimes you have proof that everybody else in the family is negative and the abuser is HIV positive, and then the test result comes out as positive for recency. And we use it as court evidence. So I'm not sure now that you're saying it's not approved by WHO. Is it okay to use that as court evidence or not really? And even the issue about getting consent. I mean,
Dr. Oka, I think that's a very good question. Yes. Because the World Health Organization is actually discouraging us from the use of the word clusters, because that implies that you are for sure the two are linked. So without that genetic analysis to say this HIV that I have is the one that this child has, it's personally in court, I would be very skeptical to administer that, because you may end up prosecuting wrong people. So we don't use clusters because there's no epidemiological linkage. It's just a time linkage of sorts. So as the Minister of Health, we are not using it for that, unless you want to look at things like acute HIV infection. Scientifically, you do need stronger evidence to say, I infected you. And that evidence has to be through genetic linkage to make those epidemiological linkages. So I'm not sure which courts of laws have been accepting this, but I think scientifically it's quite a weak case, in my opinion.
Thank you. Thanks for the clarification.
All right, thank you so much for that, Dr. Foloshi, and for your question, Dr. Jinwala. So we have a few more questions for our panel. So can recency results be provided if a patient requests for them? And then having, after the comment, having few staff in clinic, there are lots of nurses trained in HIV, but... Okay, that's... it could be, okay. So, can we mute our microphone? And we have a hand raised from Mungomba and CBPHO. You may go ahead and unmute your microphone. So can recency results be provided if a patient requests for them is one question.
So we do not provide, the results do not go back to the facility, so they don't go back to the patient. So no, the patients don't go back. The results don't go back to the patient.
Okay.
Or the facility.
Thank you so much. Mungomba, PHO, you're unmuted. You may go ahead and ask your question.
Yeah, thank you very much, Chair. Quite a very good presentation. Quite interesting. So I would love really to learn more about how we approach this as a program in the facilities. So the way it has been presented, we do not provide feedback for the recency to the facilities. We do not provide feedback as well to the patient. So, and again, recency is only targeted to the type 1. So conducting these activities at facility level, as you may be aware, we are having a high number nowadays in certain sites where you test 10 clients, for instance, but you have only 2 coming as a recent infection, which is actually a concern. So now these results are not given back to the facilities and not yet approved by WHO. So what advice are we given? Are we going by the viral load baseline way, or we are having a policy direction changes where recency will be provided back to the site for decision making? Thank you.
Thank you so much for the question. I think we missed some of what you were asking, but if I understand correctly, your concern is that the recency results do not go back to the patient and they do not go back to the facility. And the concern is, I think if I got you, how we sustain motivation with the activity. I'm not sure that I got that right. Okay, maybe just to try and respond. I'm not sure that I got the question right, but I think the thing with recency is that it's supposed to inform a public health response at a more regional level than just the facility, regardless of whether or not the patient is recently infected. The patient must receive treatment. It doesn't change HIV care. If a patient tests positive, we must try and follow up partners in whatever way is possible to try and see if they are HIV positive or not. So in that sense, the patient, whether or not the patient receives the results doesn't really change how they will be managed as an individual patient. On the facility level, for the most part, recency has been more lab-led than it has been clinician-led. And the recent infection tests are done at the same time as the baseline viral load tests. So both get sent to the lab at the same time. And then the recent infection results. So the baseline viral load will go back to the facility and management can be done at that level. But the results for the recency are then used to inform on national level. So these are, well, at least for the 6 provinces covered at present. And so these then inform on what interventions can be done at a much higher level. So which province should be receiving maybe more targeted funding? Which province should we be looking at to see maybe more targeted intervention because they have a higher than expected or higher than normal number of new infections that are being observed in this area? And so while we collect the recency testing is done at facility level, the results speak more to what happens on a national level than the facility itself. I hope that this has answered the question. I think maybe also in line with looking at the WHO approval, because it hasn't yet been validated by the World Health Organization, sending the results back to the patient, I think, would be unethical at present. And so we don't do that. It's just used for informing national policy. I hope I've answered the question. I didn't really hear it clearly. Thank you.
All right, thank you so much, Dr. Mwenya, for that. I'm trying to unmute Mr. Mungomba, but having a challenge. I hope that's answered your question. We'll take one more question from F. Kasambila. Thank you for your question. You may unmute yourself and.
Thank you. Thank you, Chair. Good afternoon. I'm based in Kawambwa and Right to Care, Zambia. My question is on is it to do with the studies around the age limit where we only do recense starting from 15 years and above? What could be the reasons around that? Thank you.
Okay. Thank you for the question. So I think we take the age of consent, I think, for our environment. And so that's at age 15 and above. I am not aware of what the scientific reason would be for not taking a lower age limit. So I'll ask if any of the panelists can answer this. But as far as I'm aware, we use the age of consent, which is 15 in our environment. Thank you.
All right, thank you, Dr. Panya. Is there anybody on the panel that would like to go for that question? So regarding the age of which recency testing could be done, 15 years of age, good enough? Is it the age of consent? Okay, so while we're waiting for that, we'll go for this very last question from Dr. Onoya, saying there's a misunderstanding on the ground. So in our context, recency testing goes together with baseline viral load, and then kindly elaborate if the baseline viral load results should not go back to the facility as well. There seems to be a misunderstanding in the results returning of recency testing and baseline viral loads. So what to do over there in that case? I think that will be our last question.
Thank you for this. The baseline viral loads are supposed to go back to the facility. They actually go back to the patient file because they're important for patient management. It's only the recency results that do not go back to the patient. And so if there are facilities that are not receiving the patient baseline viral load, please let us know and we can do something about this. They are supposed to go back to the patient. Thank you.
All right, thank you so much for that, Dr. Mwenya. So this brings us towards the end of our presentation for today. I think we've got a lot of information regarding today's presentation that we all need to gulp. And I'd like to thank Mr. Havenzu, Dr. Mwenya, Dr. Foloshi for this very lovely presentation that you put up together. And I would like to really thank the network for being very interactive today on this session. And I think you made it a learning point for everybody on the platform today. And we hope to continue having you support and learn from this program, from the ECHO program. So the time is 16:02, and we shall end the presentation here now. Thank you so much, everyone, and we'll see you next time on our ECHO program. Good day.
Thank you.
Thank you very much.